4, 3, 2, 1. We are now live.
Yeah, Manoj sir.
Yeah, so very good evening to all of you. So on behalf of Young Surgeons Forum team, I welcome you all for this today's webinar. As you all know, previously we do have around 10 episodes in the last year, and now with Dr. Gadegone sir becoming president and MOI, episodes are now being running since last around, this is 4th episode. So we do have this presidential theme of sharpen your surgical rationale and improve the patient outcomes. So for further proceedings for today's very interesting symposium on the insights into the syndesmotic injuries, I hand over to Dr. Girish Motwani to moderate and further introduce the speakers and do the proceedings.
Yeah, thank you, sir. Is it visible, sir?
Yeah.
Yeah. So, yeah, welcome everyone. So, on the behalf of Young Surgeon Forum, this is one of the interesting topic which Gadegone sir has suggested me a few weeks back. That Girish, you have to arrange a webinar on a specialty topic in foot and ankle, and we decided to go for the syndesmosis because this is one of the area where we need to have more knowledge on how not to miss and the perfect management regarding the good functional outcome. So, so in next 90 minutes, there would be our try to provide the maximum possible knowledge about the syndesmotic injuries. In today's webinar, we have President of Maharashtra Orthopaedic Association, Dr. Gadegone sir, Dr. Narayan Karne sir, who is the Secretary of Maharashtra Orthopaedic Association. We have Dr. Manoj Pahukar sir, who is a convener of today's webinar, and Dr. Devendra Paliwal sir, who is the MOA coordinator. Great faculties, we have the radiologist who is trained in musculoskeletal radiology, and we are fortunate to have Dr. Harshwardhan Jain, who is MD radiologist, is working in Nagpur since 7 years, and he is having a great knowledge in the field of musculoskeletal radiology. And today we will have his insights about the syndesmotic injuries. Next, we have Dr. Sampat Patil, who is a senior foot and ankle surgeon, AO faculty representing the India in most of the conferences. We are fortunate to have Dr. Sampat sir, who will talk on how not to miss the syndesmotic injuries, the clinical evaluation, and it would be the great training for the young orthopedic surgeons about managing these complex injuries. Next, we have Dr. Pradeep Moonot sir, who is a senior foot and ankle surgeon from Mumbai. I don't think that he requires any further introduction. People know him for arranging the great foot and ankle conferences, courses, Bombay Orthopedic Society's conferences. And recently we had a very good live surgery workshop this month on the first week. And Dr. Pradeep Moonot will cover the neglected injuries and management about the challenges which we feel when the injuries is missed or it is not properly fixed. I am Dr. Girish Motwani. I am working in Nagpur as a foot and ankle surgeon since 7 years, and my job will be to talk on the posterior malleus malunion and the syndesmotic instability, case-based discussion. Next, we have the senior orthopedic surgeon, trauma and joint replacement, Dr. Santpure, who will cover the interesting cases of syndesmotic injuries, and he is currently working in Aurangabad since many years. Welcome everyone. Next, I would like to have some brief words from Dr. Gadegone sir, and then we will proceed to presentation by Dr. Harsh.
Thank you, Girish. On behalf of Maharashtra Orthopaedic Association, myself, Dr. Gadegone, and my secretary, Dr. Narayan Karne, we welcome you all, the viewers of Maharashtra Orthopaedic Association, as well as the viewers of the OrthoTV all over the world on a very, very interesting topic, how not to miss the syndesmotic injuries. And there are stalwarts who will deliver their knowledge. They will discuss it out. There are not only the clinical cases, but there is a deliberation on radiovascular imaging also that Harshwardhan Jain is going to tell us, which is the very weakest part of a orthopedic surgeon dealing with these musculoskeletal systems. So welcome you all. Thank you very much. And for further proceeding, I hand over mic to Manoj Pahukar to introduce the first speaker.
Yeah, may I now invite Dr. Harshwardhan Jain to start sharing his screen and to start his talk.
A very good evening, everyone. I would like to thank Maharashtra Orthopaedic Society for giving me this opportunity to give a radiological perspective on syndesmosis injury. Is my slide visible?
Very clear.
Make it full screen. Yeah.
Yeah. Okay.
Yes, sir.
Yeah. So today I'll be discussing mainly on MRI and to an extent on CT about the syndesmosis ligament, how it normally looks on MRI, and we'll be discussing few cases on CT scan and MRI. So going to the basics, that is the anatomy. So there are four major stabilizers of the syndesmosis: the anterior inferior talofibular ligament, the interosseous ligament, the posterior inferior tibiofibular ligament, and the transverse tibiofibular ligament. So we'll be going to a MR case now and looking at the normal anatomy. Are the MRI images visible?
No.
Okay.
Harsh, it is freeze to your first, the first slide.
So, able to make it full screen and then start?
Yeah, it was full
Yes.
screen. I think there is some issue with the sharing.
No, it is already shared. You make it full screen.
I think you can then stop sharing and do it again, I suppose. Okay, it's.
I think now it is
The
full.
slide is not getting changed. It's a full screen only.
Okay, we are not able to see the next slide. Yeah.
No, I'm not able to.
Is it on your PC? It's not changing, or
Yeah, on my PC it's not getting changed.
oh, you have to restart it again.
Yeah. There's some...
Yep.
Girish.
Yes, sir.
Start the presentation again, sir.
Meanwhile sorting out, you can start your other presentation.
Harsh, you can.
Yeah, I'll just log off and I will again connect it.
Harsh, share again.
Yeah.
It was running smoothly on rehearsal, so I think it should go.
Yeah.
Harsh, while sharing, you press on screen button, screen option.
Share the screen and click on the window where your presentation is.
No, PowerPoint is not moving on his own computer. So he has to just close down the PowerPoint and start PowerPoint again. Rest all is working.
Can we take the second presentation till that time, Girish? I think that will
Yes,
be.
sir. Yes, sir. So we can take the second presentation.
May I now invite Dr. Sampat Patil, sir, to.
Harsh, are you okay?
And he will be talking on how not to miss syndesmosis injuries.
Good evening, sir. Is it okay if I start?
Yes,
Yes,
sir.
you can start, sir. For full screen.
Yes, sir. So,
Yes.
am I visible and audible, sir?
Yeah, perfect. Sir.
Yes. So my topic is how not to miss syndesmotic injuries. And it is important because unless we diagnose it pre-operatively or intraoperatively or even post-operatively, significant morbidity can be avoided. Now, I will just go through some cases to give the take-home message. She is a young lady doctor, and she came with such kind of injury when she had a fall from around 2 feet height. And this was an X-ray, which was literally innocent looking. But when I asked her history, and she was not able to walk weight bearing. So history was she fell down from almost 2.5 feet height, and she could not get up after the fall, and she did not walk on her own to our clinic. So that you should suspect the injury. And this X-ray was not speaking much. And look at this. Again, some X-ray shows some widening over here. And on clinical examination, that squeeze test was positive. She had significant pain. Then we advised her MRI scan and CT scan both. And look at this. This is anterior inferior tibiofibular ligament, posterior inferior tibiofibular ligament, and the deltoid ligament. Now, everything is ruptured over here. Okay. So this is a significant injury. And clinically, she was speaking more than what radiology was speaking. So one should keep it in mind. Why I decided to go for MRI first, because then if I would have fixed and then later on discovered it, then it would have been a problem to do MRI as well. So my usual plan is I ask them to get MRI done, and limited cut CT scan, they do it free of cost for us, because it is even easy for radiologists to pick up and read the injuries. So for patient also it is economic, because you are doing it before your fixation. And look at this now. Now this is complete reading of injury. This is open up, and this was a stress view, like standing. She could not stand completely, but whatever amount of weight she was giving, it is completely opening up, isn't it? And this is what one should read. Higher the fibula fracture, more are the chances that the injury, syndesmotic injury, be more severe if it is there. So this is quite opening up significantly. Fibula fracture is high up, so it's a difficult situation. So one should not only read syndesmotic injury, but one should know how much it is going to be a tough job to fix it and to treat this injury. So one should identify the magnitude of problem by clinically suspecting it, by noting the injuries, amount of injuries on MRI as well as CT, and even stress views. So everything correlating is going to give you the magnitude of problem. It is not only one thing which is going to give you the answer. I'm just giving you the hints to diagnose it, because my colleagues are going to talk, and even through cases we are going to talk about management. So I'm just limiting it myself to diagnose. Now another case, fibula fracture and middle malleolus fractures. Look quite innocent bimalleolar fracture, but look at this. So again, lesson is, when starting, also start with stress view, isn't it? If pre-operative your patient, because of pain, he is not able to do it for some reason, document this. Otherwise, even you will not remember while you end up your fixation, and sometimes you even miss it. So this is significant syndesmotic injury again. And I will just go back to this X-ray. Looking at this X-ray, it's just a, they will say fibula fracture, middle malleolus, fix it and just finish it. But when we start, do not forget this. This was just simple stress view, and it was wide open. So syndesmotic injury probably should be suspected and then documented. And look at this. Then we had to reduce it, of course, reduce the fibula fracture, but reduce the syndesmosis as well. And then fibula fixation and syndesmotic fixation was done. And this is how, as near as possible, the screw should be at the syndesmosis. I will not go into that detail. Now, again, innocent looking injury, a fibula fracture. But clinically, he was speaking more than what an X-ray would be speaking. He could not walk, he could not weight bear, squeeze test is positive. Of course, at fibula, because of fracture also, it was painful, but it was more than that fibula fracture. So, okay, that video is not. Now, then again, we did MRI scan and look at this. Even deltoid was ruptured, and it does contribute to the stability of syndesmosis along with anterior inferior tibiofibular and posterior inferior tibiofibular ligaments. And we did not repair deltoid, but 2 syndesmotic screws needed to be inserted. So again, innocent looking X-ray, but clinically I could not show this video. Clinically, he was absolutely unstable. So clinically, one should document this, and one should see pre-operatively or intraoperatively, at least before we start fixation. And this is how we ended up in fixation. Post-operatively also, you should keep it in mind whether you have done a correct job or not. Try to, if it is a CT scan center is in your hospital, try to see that, do screening and look at this. Now, after this fixation, I saw whether my reduction is good post-operatively as well, because even post-op mal reduction is also very common. So we have to suspect it pre-operatively. Intra-op, you have to again do the stress view, and post-op also, if you have done complete job at these 3 levels, one should not miss evaluating syndesmotic injury correctly. And even this CT scan, because I did not repair deltoid, so I wanted again to check on the medial side as well. Now, if you want to diagnose pre-operatively, probably the clear space is the good indicator of diagnosing it rather than tibiofibular overlap, because the tibiofibular overlap in different kind of rotations may be different. So these parameters should be kept in mind, that probably medial clear space is a good indicator to know if there is a syndesmotic injury or not. Gravity stress view, yes, something at Weber B at transsyndesmotic level. One should know about gravity stress view. You can externally rotate it, hang it below the edge of table, and fibula should be facing the ground, and you take AP view. If it shows that this is increasing, then again we are dealing with syndesmosis, which is unstable. Intraoperatively, we know about hook test or dorsiflexing and externally rotating the foot into the mortise and see the instability of syndesmosis. But again, you have to just suspect it, then only you are going to do all these things. In fact, every of my colleague, I tell that never end your fixation or never leave your OT in bimalleolar, trimalleolar fractures unless you see the syndesmotic stability. Sometimes we just get carried away that, oh, I have fixed it nicely, the lateral malleolus, posterior malleolus, medial malleolus, and then I'm done. But in spite of, there are some scenarios when in spite of posterior malleolus fixation, they will need syndesmotic fixation. If you have suspected it, if you have reduced it, see the reduction as well. Try to see it clinically and look at this. This was fixed myself. I have fixed it with the fibula plate, but this was unstable syndesmosis, which was fixed with syndesmotic screw, little above than what I should have done it. But what I want to show is this patient was unhappy post-operatively. He was having pain because of this. I have used partially threaded screw, and look at the CT scan. This is over compression at the syndesmotic level. So even it should be a fully threaded positional screw, because compression at the syndesmotic level will be an issue. And once I removed it, I removed the screw, patient was happy. I removed the screw, patient was happy because probably it was over compressed by my partially threaded screw. So malreduction is also common. So pre-op, intra-op, and post-op as well, you should know what you have done to the syndesmosis. Another case, again, you have to suspect it. I will just run through it because I'm running a little late. And last, I'm going to show you where it is only ligament injury, then without fracture, if it is there, like footballers, if you are suspecting it, your squeeze test is positive, you have done MRI, our radiologist colleague is going to talk about the ligaments which are getting involved, then probably arthroscopy is the very important tool. And look at this now. This is tibia, this is fibula, and see this, it is so unstable. To diagnose purely to diagnose purely ligamentous syndesmotic injury, probably your suspicion, your clinical examination, and advising MRI at right this thing. Then who are people who will require this? Footballer who has a fall and unable to bear weight, your squeeze test is positive, do advise MRI or at least stress test. If syndesmosis is opening, keep it in your mind that probably isolated syndesmotic injury is also there, or at least see proximal fibula fracture if it is there and try to assess it. So suspect the injury and document the stability. So that is a simple take-home message I want to give. Unless you suspect or document it either by stress view, MRI or CT scan, probably there are chances that we may miss the syndesmotic injury. Thank you so much.
Yeah, thank you, Sampat sir. Great presentation as always. Sampat sir, few quick questions. Like you mentioned that stress examination is very important to diagnose the subtle injuries which are missing on the plain X-ray. There are two types of stress examination. One is external rotation stress view, which probably your video was not working, and the gravity assisted stress view, which you already explained it. Sir, can we have your opinion about both the views, like how to do in short, and what are the advantages and the disadvantages of doing both the stress view for the young orthopedic surgeons?
Sure, sir. So actually, gravity stress view is easy to do, and if patient has moderate pain, then it is better to do probably standing view, because standing view will yield more information in terms of stability. If patient is able to weight bear, probably standing view I will prefer. I don't know about literature which is better than the other, but standing view is always going to document you more clinically matching finding. Gravity stress view is also helpful. I will just show you. You just externally rotate it, take the fibula down, and then if it opens up medially, then probably you are dealing with the syndesmotic injury. But it is mainly helpful in patients who are having Weber B at the trans syndesmosis. Standing view, probably if patient is able to do the standing, it will be more helpful preoperatively. And intraoperatively, probably dorsiflexion, as you said, dorsiflexion and external rotation should be the way to go ahead.
So there were many literatures on the comparative test on the syndesmotic injuries, and majority of the time they have concluded that both the stress examinations, they are equally sensitive and specific. The only thing is the gravity stress view is more patient friendly. Do you feel that this is more patient friendly in acute condition? Acute traumatic?
Absolutely, sir. On the contrary, that's what sometimes patient just refuses to stand, or even if he or she stands, he will not put the weight on it unless you have a proper technique that the sound leg should be up and behind, and he should be totally standing on the affected limb. Otherwise, unknowingly, he will offload the affected side. So he should be that way taken properly.
Any question, Manoj sir?
Sir,
question in chat box.
Sir, after fixing the syndesmosis with the additional screw, still, and then it is very difficult to judge whether it is over compressed or it is in the normal tone. So this is a very difficult situation. So in that case, how to go ahead with this?
Yeah, very important question, sir, which I have done in that patient. I had done that because I used partially threaded screw. So it should be only a fully threaded screw as a positional screw. That should be there. And trick is you have to pass one K wire, sir. You have to pass one K wire as a derotation guide wire. Keep the K wire there. You are holding it by pointed reduction clamp like that, passing on one K wire, and then you pass a screw so that your screw is not going to change the position of fibula which you have already reduced well. So not to over compress, just keep it there. And I always tell this point that this is the lip of tibia, sir. It has to sit nicely in this lip of tibia. This fibula has to sit there nicely in the lip. See, this is anterior lip, posterior lip, and this fibula has to sit nicely. And you use mosquito and just see, this is slide from anterior lip to fibula and then to and fro, so that you will know it is sitting on nicely. And don't over compress, and use positional screw, that is fully threaded screw, so it will not over compress. And another point not to over compress is don't go too high up, sir. If you don't go too high up, then there is chances, see this, sir. There are chances that you will tighten up. Just go as near to the syndesmosis as possible. These are the few.
Sir, how often even in the doubt, how often you require to open the syndesmosis just to check whether we are perfectly done or not? Is it necessary to do it?
I always do it, but I don't open. See, anyway, for fibula plating, sir, you are taking this approach. Okay. Now I will just show you. You have taken this approach. Don't nude it. See this. This is my mosquito. I am standing on the anterior lip of tibia at syndesmotic level, and just going to feel it, fibula. Oh, it is sitting nicely. If it is reduced anteriorly, you will feel fibula only. If it is reduced posteriorly, mal reduced posteriorly, you are going to dip down. So always try to feel with mosquito. Don't open it unnecessary, because then you have to cut the anterior inferior tibiofibular ligament. But then with mosquito is your finger. Just do like this. Nice way of doing it, so that you can know that you have reduced it nicely. That's why I showed you my photo also, that I just always do this. On Shyam, just see that you are standing here, and then see this lip.
After how many days you want to remove the after screw? Is there any permanent feature, or you advise to remove the screw?
Usually I don't remove the screw, sir. I do inform the patient if it is little mal reduced, it will break on its own and then get auto stabilized. But like that patient who are unhappy, who are not getting movements, it was stiff. That time I removed it and I found it, but after 3 months. I mean, if patients are unhappy, or if your CT scan post-op is not showing good, then it is worth. Otherwise, usually well reduced and well done patients, we will not remove it. Let it break and it will auto stabilize.
Sampat, is there any indication for putting two syndesmotic screws?
Higher the fibula, sir, and you are managing indirectly, probably I will use 2 screws, but there is no literature support as such. It is our personal feeling that it is too high, like that Wasudeo injury, too high, and you are afraid of putting plate there. Now, recent literature says that even go to that higher level to fix it. But if you don't want to really go that high up, then probably alone one screw holding everything, let's look. And so at that time I put 2 screws, but even while putting that screw, we are putting it in intact fibula. So I put small plate, and through small plate you can put the screws. Some people will say that, okay, there is no fracture is up, but then it is like a stress riser. Why to put the screws only through fibula? So I will put just 4-hole screw, a 4-hole plate, or 4-hole plate, which is 1/3 tubular, and just put 2 screws there. But no literature support as such, sir. 1 or 2 screws is still open debates.
Yes, Sampat sir, last question.
Sir, will you use a locking small plate with locking screw, or a simple screw?
I use a simple screw, 1/3 tubular plate, non-locking screw, sir, because I feel that locking screw is more prone to break away, because it will be angular locked.
What do you do if there is combination from the insertion of site from your screw? If there is a combination at that point?
Yes, that is a good question, because it is possible. So that time you see that try to go nearer and away from comminution, but sometimes probably if it is not possible, then you will have to go, because syndesmotic stability is important, and that way fibula non-union will not happen just because you are going. But try to avoid it. It is possible. And one more clinical tip, sir. If you are putting the screw, actually your direction has been decided when you have drilled fibula. Suppose I have drilled the fibula like this. Afterwards, you are not going to change it. So if at all, what I do first, I take K wire 1.5 or 1.8 mm. I see how it is going nicely in fibula. Because same guide path, it is like a guiding hole, this thing. Same I am going to enter in tibia. Later on, I cannot change my direction. So try to see first in fibula, that direction only your screw is going to follow.
Yeah, thank you, Sampat sir. Great presentations, lot of learning points. Now we can move to Dr. Harsh. Harsh, you can share the screen. We can take the other questions at the last, sir, because we are running short. So Harsh, please continue.
Harsh, you are muted.
Harsh, you are muted, Harsh. Please unmute yourself. Harsh, am I audible?
Girish, you're audible to us.
I think there is some another technical issue, I suppose.
Harsh, unmute करो. Hang हुआ है? Okay. Yes. So
stop sharing maybe.
I think there is some other problem. He's hanged in his computer. So
ask him first. Stop sharing. I don't know whether. Okay, it's done.
Sir, am I audible now?
Yes, Harsh. Please continue.
Extremely sorry for these technical glitches.
Yeah, no problem, Harsh. Share your screen.
Yeah.
How big is your PowerPoint presentation, Harsh?
Sir, it mainly includes cases. I have just got 3 or 4 slides, but there are cases which I need to discuss.
Harsh, you are very audible and visible. Please go ahead.
Yeah. Are the MRI images clearly seen on the screen?
Yes,
yeah.
Go ahead.
Yeah. So we'll be discussing with the normal anatomy of the syndesmosis ligament of the ankle. So these are the 3 sequences what we usually take. This is the coronal sequence. Just brief anatomy. This is the medial malleolus, the talar dome, tibial plafond, talar dome. Laterally there is this lateral malleolus and the fibula. So with this, just the most important stabilizer, what we see is this black band, which is most commonly injured. That is the antero-inferior tibiofibular ligament. Now we can see the orientation of this ligament is oblique. It's not a straight ligament. So if we plan a routine MR, or if we have a look at the routine MR, there will always be some kind of a discontinuity or a break we'll be seeing on a axial sequence. So it's very important that our MR should be oriented in a oblique way, 45-degree oblique way, so that we see the thick band in continuation. This is the anterior syndesmotic ligament. Now, if we don't plan the MRI oblique sequence, we will be seeing a discontinuity and a tear in almost all the cases. So this is about the anterior syndesmotic ligament. Once we go posteriorly, there are 2 thick structures which we can see here, again on the oblique sequence. So this is the posterior inferior tibiofibular ligament, and below that will be our transverse tibiofibular ligament. And cranially, we can see this structure here. This is the interosseous membrane. So these are the important normal anatomical structures pertaining to the syndesmosis. Also, the deep fibers of the deltoid. This is how it looks on normal MR. The superficial fibers of the deltoid, and this is the tibialis posterior tendon. So this is about the normal anatomy. The important thing is it should always be in a angulation. The planning should be in a 45-degree angulation so that we don't overdiagnose the anterior inferior tibiofibular ligament tear. Now I would like to introduce one relatively new sequence what we have started taking recently. And sir was talking about like we need to do a CT scan and a MRI screening for all the syndesmotic ligament injury. Now, if you look at this 3D PD sequence, is the window clear, Girish?
Yes, very clear. Go ahead.
Yeah. So this is our 3D plain PD sequence. We have not suppressed the fat here, as we can see, taken in sagittal image. Now we can make it 3D MPR just like our MRI image. Yeah. Now the beauty of this sequence is, first of all, you will be able to see the cartilage along with the bone properly. So in case of any osteochondral injury which can be associated, we will be able to pick that. Secondly, the visualization of the ligaments is as clear as in the other sequence. We can see this is the anterior inferior tibiofibular ligament. Now once we angulate this, we can do it after once the MR is done, and look at the axial sequence. Yeah. So the fibers are in continuation. So there is no separate planning which is required for this sequence. The sagittal images can also be seen well, and it takes just 7 minutes for us to take this sequence. It gives us both bony anatomy, ligamentous anatomy, and the cartilage to see properly. So this was in brief about the normal anatomy. Now let's move on to the case. Are the CT images visible, Girish?
Yes, Harsh.
Yeah. So this is a 35-year-old guy who had got a ankle injury, and the CT scan was done. Now we can see on these coronal images that there is a classical transsyndesmotic fracture which is seen in the distal fibula. Now another important finding what we are seeing here is the injury to the posterior malleolus. Yeah. Again, for visualization of the posterior malleolus, sagittal images may be preferred over the coronal images. So this is the fracture. This is the posterior malleolus fracture, and we have got the transsyndesmotic fracture. Now we are suspecting a supination exorotation injury here. So for a posterior malleolus fracture to happen, there has to be a anterior inferior tibiofibular ligament injury. Now if we look carefully, we can see that there is a small bony chip which is seen along the tibia. And if we look at our axial images, this is the fracture chip. So there was a avulsion injury. This is the attachment site of the anterior inferior tibiofibular ligament, and there was a avulsion injury here. Also on the axial images, we can see the asymmetry in the space, which indicates that there is a instability. So it's a Weber B fracture, stage C. Now what's happening to the medial malleolus? Again, going back to our coronal images. So grossly, we can see that the medial malleolus looks okay. There is no avulsion. But if we scroll down to the images, we can see that there is a small bony chip which is seen here. So this patient underwent the MRI scan. Yeah. And these are the MRI images. Are the images clear, Girish?
Yes. Go ahead, Harsh.
So this is the image of our case where we are seeing that there is an associated grade 3 injury of the deltoid. Now, just for reference, this is how a normal deltoid looks. This is the grade 1 to 2 injury where there is thickened edema, and this is grade 3 where there is a complete rupture with associated injury to the talus and the medial malleolus. So it was a case of a supination exorotation injury, which is a stage 4 injury, associated full thickness tear of the deltoid, which was seen on MRI. Now going to our next case. Yeah. Are the images seen? I've changed the case.
No, Harshwardhan, I think you are stuck up with the last previous MRI only.
Okay. Is it seen now?
No, you have not shared your screen. I think you need to share
I think
again.
there is a issue with that. It has, the laptop has got hanged. The share screen is not working, unfortunately.
Okay.
Extremely sorry for that.
Okay. How many cases you are left with?
Yeah, this is one case and then few slides. Some technical issues with the laptop. Yeah, I think now it should.
Yeah.
Yeah. Okay, so this is another case. This patient came to me yesterday. Now, he had got an old injury around 2 months back in Dubai. He was managed conservatively for this infrasyndesmotic fracture, the injury, or a Weber A fracture, what we can see on this CT images. Now, posterior malleolus looked okay. There was no obvious avulsion along the medial malleolus. Some kind of a sclerosis is there in talus and medial malleolus, but we didn't see any avulsion fracture. So predominant CT finding was a Weber A fracture for which he was managed conservatively. But in spite of that, the patient had persisting instability. So we decided to go ahead with the MRI. Yeah. So this is the MR image. Is it seen?
Yeah.
Yeah. So yeah, so we can see this fracture line, which was again seen on the CT image, the infrasyndesmotic fracture. Now, if you look at the ligament fibers as such, the anterior syndesmotic, posterior syndesmotic ligament, it looks intact. But what's happening on the medial side? We can see that there is a complete rupture of the deep fibers of the deltoid. There is a discontinuity here and the fracture of the talus bone. Yeah. On sagittal images, we can see that there is a fracture in the body of the talus. The most important finding was the complete rupture of deltoid, and there was a cartilage injury along the navicular bone with an early talonavicular joint arthritis. So sometimes, like we expected, just after seeing the CT, I was expecting it to be a supination adduction injury, a Weber A fracture, but sometimes there can be a mixed pattern of injury. In this case, probably there was a pronation stuff also, which has resulted in the complete rupture of the deltoid. Yeah. So the first case where we discussed a Weber B fracture, a subination exorotation injury, this was a typical pattern. There was a rupture of anterior tibiofibular ligament. There was an oblique fracture which was seen along the distal fibula, the avulsion of the posterior malleolus, and complete rupture of the medial collateral ligament. But the second case, it didn't follow the typical pattern of supination adduction injury where there was an associated complete tear of deltoid. I will just skip the classification. So this is how we grade an anterior syndesmotic injury on MRI. This is the normal appearance. Now in grade 1 injury, what we'll be seeing, there will be a thickening of the ligament. There can be some edema, periligamentous edema, but it will be taut and the continuation will be maintained. Now in grade 2 injury, what will happen? There will be a kind of a wavy nature and irregularity of the ligament. And in grade 3, that is the complete tear, we will be seeing that there will be a focal discontinuity of the ligament or a avulsion injury. So I'll be skipping.
Not able to see. I think those.
Sir, the MRI images are not seen.
We are stuck on a single image which was there previously.
This.
Maybe I can.
I think there is some issue with the laptops. It's not.
Okay. Okay, you just stop sharing and redo it. I think you do have only few slides left.
Yeah, just few post-op slides and
yeah,
just
stop sharing and do it again. That might help.
Manoj,
Yeah.
we will get with the next lecture.
Actually,
he need to change the laptop.
That's a very interesting case which has shown I think infrasyndesmotic fibular fracture and associated deltoid ligament injury. I think this is very rare. What do you think, Pradeep sir?
So I think that's a complex injury because it's not only just deltoid plus fibula or Weber A, but also the talus is gone. So it's more like an abduction where the deltoid is gone, but at the same time, then he probably had some impaction on the talus as well. So it's a unusual injury. And that's why probably when you suspect, and we will listen to it on my talk as well, when you suspect all these kind of injuries, you have to have your radiologist as your best friend who will guide you through both the CT and the MRIs, and you can sit down with them and go through these images properly.
That's what I tried to come out, because that would have been neglected even by us. Only a simple distal fibula fracture.
Correct.
And then it becomes a neglected. So I invite Dr. Pradeep Moonot sir for his.
Hello.
Harshwardhan, we take your case maybe.
Okay. Just few slides. Actually, the cases are done. So
okay. Pradeep sir, we'll have his short brief.
Sure, not a problem.
Extremely sorry for this. Yeah. Is it seen, sir?
Yeah. Please.
Yeah. So sorry, I was just talking about how we grade the injury. This is the normal anterior syndesmotic ligament. This is how a grade 1 injury looks, where there will be a thickening or there can be a slight edema. This is a grade 2 injury where we can see where there will be some waviness along the fibers, and a grade 3 where we can see that there will be a discontinuity and a complete rupture. So I'll be skipping the X-ray side. Now, sometimes it is very obvious on X-ray and we see a grade 3 injury. Sometimes the space can be maintained or a borderline normal, and still there will be a grade 3 injury. So I'd like to discuss the post-op assessment which sir was talking about. A post-op, whether there is a persisting syndesmotic instability or not. Earlier, what we used to do was a side-by-side method where we used to scan both the ankles and compare the right and left side, but there were a lot of mistakes and it was not that accurate. So now there are various parameters we look for to look at the post-op stability of the syndesmosis. Now these parameters, they include the anterior and the posterior difference, the middle difference. Now we have the direct anterior and the direct posterior difference, but the important ones which I want to highlight, or which are the most accurate ones, is the calculation of the syndesmotic area and the calculation of the fibular rotation angle. Now, these are the most important parameters. The syndesmotic area, more than 140 millimeters square, it indicates that there is a definite instability. And the fibular rotation angle less than 8 degrees, it means that there is a instability. This is from American Orthopaedic Foot Ankle Society 2019 article. So just a take-home message, 3D plane PD sequence. It's a single sequence which can solve the problem of both CT and MRI visualization of bones, ligaments, and cartilage. If that's not available, always ask for oblique sequence whenever you want to look for syndesmotic injury. A routine MRI axial scan, we will be missing out or over-diagnosing an anterior syndesmotic injury. So MRI will always add up to the additional information which will be missed on CT. Ideally, what I do here is we do a 3D CT and a 3D MR sequence which gives us both bony and ligamentous anatomy. And post-op CT, the syndesmotic area calculation and the fibular rotation are known to be the most specific parameters for this. Thank you.
Yeah, thank you, Dr. Harsh. I think it was a wonderful presentation, though it was in different patches.
Yeah.
We could get this take-home message, very important. This even this syndesmotic area and femoral rotation to assess post-operative CT is another very important factor. Thank you, Harsh. You can stop sharing your screen.
Yeah.
Yeah. Now, may I invite our next speaker, Dr. Pradeep Moonot, sir, to start sharing his screen, and he will be talking on the neglected syndesmotic injuries and the various challenges we face in treating those injuries.
Can you see my screen and hear me?
Yeah,
Yes, sir.
you can make it full screen. Yeah.
It is full screen, I think, isn't it?
Not yet, sir.
I think, okay, I made it. Is that okay?
I think we are able to see the complete presentation, not the full screen.
Okay, hold on. I'll just stop share again.
Yeah.
Never had an issue. Hold on, sorry. I know what it is about. Okay, give me 1 second. Yeah.
You can start the presentation and then.
No, I know. Means I normally never had an issue with
Yeah, I know.
Yeah.
Still not.
I can see my whole screen, so I'm not seeing as I'm seeing as a running slideshow. Anyway, for the sake of time, I think we are quite.
I think we can. We're able to understand still with this
fine.
view only. We can.
Sure, that's fine. Thank you so much. Both, I would like to thank Dr. Gadegone sir, Girish, and the Maharashtra Orthopaedic Association for inviting me for this Young Surgeons Forum. We have already heard 2 excellent talks by both. How you do not miss syndesmosis by appropriate examination and clinical findings and X-rays, and of course need the help of your radiologist to see if you need a CT or NMR. But if you're unfortunate, either you miss it or a patient comes later, then what do you do? That is the aim of my talk. In the next 12 to 14 minutes, I would try to cover that. So just start with a case of 48-year-old male, pain in the ankle since last 1 year. Probably a history of twisting injury 2 years back, which was not taken seriously and no specific treatment taken. And here you can clearly see something is going on in this
slide
area.
is not moving, Pradeep.
No, I have not moved yet. Don't worry.
Okay.
Now that's moved. So tenderness present on the syndesmosis, mild tenderness present on the medial malleolus and normal alignment.
Pradeep sir, it is not moving.
You can see the CT scan, no?
No. We have not seen your case, sir.
Now it is visible.
Now it is, yeah.
Interesting.
Pradeep is a seasoned man, still he is getting problem today.
I don't know. So I think it is a Zoom. It is not me. Can you see the CT scan?
Yes. Please move the slide, sir. Please
Now?
move the slide. No, it's not moving, sir. It is freeze to CT scan.
So I can, okay, hold on. I don't know. Then it is Zoom. I don't think so. There is an issue. It is issue with something else because I can see it moving in my PPT. Hold on. Again, I'll start sharing it. Yes. You can see the CT scan?
Yes, we can see full screen now.
Now I'll go full screen. Yeah. Yes, you can see the CT scan, correct?
No, not full screen.
Just freeze down to that same. Mahek, is this the Zoom meeting problem or?
I think the meeting is running fine, but you can try sharing again. Like do it 2-3 times, maybe then it can
I've done it. So because it runs on my stuff, but it doesn't. Okay, hold on. Again, start sharing. Share. There. You can't see anything or you can?
Pradeep sir, you go to screen option and then click to the window.
So I'm not, that means it's a normal thing. You share your PPT and then
No, so rather than sharing the PPT, you go to screen option. Screen.
Okay, hold on.
Don't just share the PPT, share your whole screen. You can try that, sir.
You can close down the PPT and then restart again.
Let me do that. I think that may be a better option. Okay, one more time. Share. There, can you see?
Yes, sir.
Okay, now you saw
Full
this
screen.
full screen I have done. Case, can you see the case?
Sir, we are seeing your half screen. It's not fully shared.
Okay, I don't know what to do. The other option is I could do is I just run it this way.
Yeah, sir.
that-
This is perfect. Perfect, sir. I think this is perfect.
Okay,
Are
so
able to see
there
the
is an
case?
issue with if you go in a slideshow, there is an issue. That's what I think. Even Dr. Harsh had it.
Yeah, yeah. I think so.
Okay, so I'll just go through this like that. Okay.
It's perfectly fine, sir. Yeah.
Yeah, so I'll start with the case. 48-year-old chap, pain in the ankle since 1 year, history of twisting injury 2 years back, and no specific treatment taken. And clearly you can see what is happening in this ankle joint. There was tenderness present on the syndesmosis, mild tenderness present on the medial malleolus, and he had a normal alignment. CT scan was advised, and you can clearly see comparative CT, that's a normal side. Here, it is not normal. Here you can see something is happening in the syndesmosis. The fibula is displaced anteriorly. There is osteophytes present. And of course, there is narrowing of the joint space anteriorly. For the sake, MRI was also done. I will not go because of time. Now what? What do you do? So this is where my topic of neglected syndesmotic injuries comes in and treatment challenges. So what are the causes and what can happen if a patient has a neglected syndesmotic injury, either because of isolated or because of a multitude of fractures around the ankle? So the causes is either because of missed injuries, isolated, could be because of malreduction or malunion. Here you can clearly see this patient had a bimalleolar fracture, beautifully fixed medial malleolus, beautifully fixed fibula, but the surgeon forgot there's something called a syndesmosis and the ankle is going in valgus. Also, if discussed before, either the fixation is not proper or the patient mobilizes too early or the fixation fails before healing, you can have something like this and the syndesmosis opens up. Presentation wise, sorry, this GIF is not working, but the patient has persistent pain on weight bearing and may complain of ankle instability depending on only isolated or other ligament injuries are there or not. Patient can also have a deformity, especially if it is a significant opening of the syndesmosis. You can have a patient coming with a valgus deformity of the ankle joint and progressive loss of function as well. On physical examination, there is tenderness present over the anterolateral aspect. Patient may complain of swelling over the anterior aspect or a generalized ankle swelling. Patient has reduced dorsiflexion and instability. As I said, again, if they have a deltoid instability along with the syndesmosis opening up, they may feel that they are falling over, not confident on the leg. Special tests already discussed before: external rotation stress test, squeeze test, a cross-legged stress test. These are all special tests which we would do it for acute syndesmosis, works valid or is valid even for subacute or chronic syndesmotic injury. The main aim of the talk is how do you manage these type of injuries? So the way to differentiate these is first, of course, investigate them properly, and then we come to the treatment. Already we have spoken about bilateral standing x-rays. You have, sorry, this would have been on the, I would not try to do this in a PowerPoint. So, but let's see. So you check for a tibiofibular clear space. There should be no clear space between the tibia and the fibula. There should be definitely some overlap present, and the medial clear space should be equal throughout the ankle joint. Here you can see on the x-rays on your left, that's a normal x-ray. On the right is an abnormal x-ray of one of my patients. You can clearly see tibiofibular plate is opened up. There is no overlap of the tibia and the fibula, and the medial side is also opened up as well. On the lateral view, especially standing, always look how your fibula is placed compared to the posterior part of the posterior malleolus. Usually it should be within 2 millimeters. That's a normal ballpark figure. It can vary between that range. So if you're doing a standing X-ray, see, sometimes the fibula can be displaced quite anteriorly, sometimes very rarely posteriorly. And especially if it is post-op, check the alignment and see if it is displaced. Of course, you will do further investigation to confirm it, but it's a good starting point. Stress which we've already spoken. If there's 2 millimeter widening of the medial clear space compared to the normal side, again gives an indication of syndesmosis plus minus a deltoid injury. Now, when we talk of CT scan, and especially many times I ask for a CT scan in the center, then let's talk about the radiology center. You would just send you the affected side. If you're looking at your syndesmosis, ask for both ankle CT scan, and they should be almost at the similar level for both sides, and compare it on the other side. Of course, briefly, when you're looking with your eye, naked eye, check for the position of the fibula in the incisura, if it is significantly anteriorly displaced or posteriorly displaced. And other measurements which Dr. Harsh Jain has already mentioned, those you can sit down with the CD of the CT scans and then look through it. Also, one more thing I would really like to emphasize, do make sure you ask for a 1 mm cuts. A lot of times, the CT, they may do a 2 mm or 5 mm to do it very quickly and sometimes to save cost as well. But you ask them for a 1 mm cut, because if it is more than 2 or 3 mm, you may miss the injury or you may miss a mal reduction or a mal rotation. So that is one more thing which you need to do as well. MRI can be very sensitive and more specific than a CT. Sometimes it is too, I would say, sensitive and specific. Sensitive, I would say, for osteoarthritis. But a lambda sign on coronal images with more than 2 mm of diastasis can be a pathognomic of a syndesmotic injury. Arthroscopy, I think this was a video. It may play. Let's see, I don't know. Yeah. So here you can see, I think Dr. Sampat Patil also mentioned it. If it is an isolated syndesmosis injury in sports, you can do an arthroscopy and see how in this chronic patient who had pain on the anterolateral side, you do a squeeze and you can see how the scar tissue come into the joint. So that's abnormal syndesmosis present. Also a direct visual, also when you're doing an arthroscopy, you can do a debridement of that and then go on and do a fixation if required. At the same time, if there are any OCD lesions, you can deal with them along with the synovitis as well. Treatment wise, I divide these patients into either just having an isolated syndesmotic injury or there's a multitude of other things happening like a malunited fractures of the fibula, the medial side and other on the posterior malleolus. So how do you deal with this? So let's start with an isolated syndesmosis. You place the patient in a supine position with a bump on the same side. Do a longitudinal incision, but try to err it slightly anterior because you want to see the syndesmosis. Once you see the syndesmosis, then you put in a laminar spreader, start proximally around 5 to 6 centimeter proximal to the syndesmosis, open it up and gradually start distracting the syndesmosis and start debriding it from the proximal part and then move it towards the distals. And as you move distally, move your laminar spreader also distally. When you do that, you will come to a point where the whole syndesmosis you have debrided, and through the syndesmosis, you should be able to almost see the talar dome. That means you have done an adequate debridement and opened up and removed all the scar tissue for further management. Once you have done that, suppose you cannot reduce the syndesmosis, then you open up on the medial side, remove all the scar tissue, clear the medial gutter both medially as well as anteriorly, and then look at reducing the syndesmosis. You make sure your syndesmosis, as Dr. Sampat said, you are on direct visualization, the fibula should be nicely sitting into the incisura. And then you can use a pointed clamp where the clamp should be placed in such a way that the points of the tongue can be seen directly on the AP view of the CM images. Okay, along the transmalleolar axis, pass your wires slightly posterior to anterior 15 degrees, temporarily fix it. Now, we spoke about what type of fixation and everything, especially in chronic neglected subacute injuries. I would put 2 4 mm 4 cortices screw over a plate. Now you may not use a plate, but most of the time these patients have not walked on their leg or the limb, and can be a chance of osteoporosis and try to, or maybe a fracture if you use 4 screw or 2 screws, large screws. That's why putting over a plate is a good idea. So use a 3 or a 4 hole 1/3 tubular plate and put 2 screws, 4 cortices. Now, other types of fixations have also been described, especially for non-arthritic syndesmosis. I spoke about 4 cortices. You can also do a reconstruction of the syndesmosis, especially recently Kadakia's et al. Paper, where he has used allografts of the hamstring tendon and going from the lateral side, coming on the medial and then fixing again on the lateral side. He passed that, you fix or reconstruct the reconstruction of the syndesmotic ligament, and then using a tightrope as well to reconstruct the syndesmosis. Now, if you have an arthritic syndesmosis, severe incongruity or low demand patients, you can do a syndesmotic fusion as well, where you, after do a debridement, you need to use bone graft because there is a big gap present, and then do a fixation like this. Now, what does literature talk about syndesmotic injuries? Is there any difference between arthrodesis and reconstruction? Stephen Remal's paper 2020, there is no difference in the outcomes. Also, another paper on functional outcome of fusion versus reconstruction. Again, no difference between those 2 methods. So that's for isolated. If you have a mal-united syndesmosis, then there is a sequence of things you would need to go through it. You need to go through implant removal, do an fibula osteotomy, lengthen and correct the rotation of the fibula. You need to debride the syndesmosis, then look at fixation of the syndesmosis, and then assess on the medial side. Just quick note, do an osteotomy to obtain the fibula length. The plate is secured. And then how do you do lengthening? You can do multiple ways. You can put a laminar spreader into the osteotomy, or you can put a proximal screw and use a laminar spreader through that and get your length and your rotation right. Once you get that, you can fix it proximally, or you can fix it distally and then proximally, or vice versa, whichever way. Debride the syndesmosis, clear the medial gutter, and then fix it with whichever way you would like. Now, just going through 1 or 2 cases before I finish. So coming back to case number 1, we saw the CT scan, saw the MRI scan. Sorry, let's see if I can run that. Hold on. Yeah. So there it is. I did the arthroscopy, cleared up the gutter. Here you can see the syndesmotic scar tissue significantly, clear that up. And here, there you can see the squeeze test. Once you do the squeeze, you can see the whole scar tissue coming into the syndesmosis. Clear that up and then fixed it with 2 screws over a plate. That's post-op, that's 1.5 follow-up, no issues, and he's doing quite well. Another case, 50-year-old male, 6 months later with deformity. That's a CT scan. So again, opened it up, got the length, cleared up the scar, the syndesmosis, cleared up the medial side, got the length, got the rotation. Again, pre-op, post-op. And also, in the end, I think medial side, he was quite unstable, so did a deltoid reconstruction. Last case, 46-year-old female presented with increasing pain and deformity. And she said she's a teacher and can't stand and teach. She had an ankle bimalleolar fracture 10 years back, and this is what she was fixed it. So again, fibula and medial malleolus fixed. See the syndesmosis and see she's getting arthritis. So I did an arthroscopy, assessment and debridement, opened it up, cleared it up. Now, of course, there was arthritis in the ankle. So I had given her an option of a fusion versus reconstruction. And she was very, very adamant that she does not want an ankle fusion done, that she was very clear on that. So that's why we went ahead with this, remove all the implant, debrided the syndesmosis, did a fibula osteotomy, just left it for some time, opened it up on the medial side, did a fibula supramalleolar closing wedge osteotomy, closed the did a closed wedge SMO, fixed it. You see how the length has automatically come, got the rotation right, fixed with 2 wires, and then started fixing on the lateral side. So that's the pre-op, that's the post-op, and here you can see fixed one with a screw and one with a tight rope. She's almost 2 years follow-up. She comes regularly with a little bit of pain, but she's been managing herself well and hopefully waiting. She's saying she's waiting for an ankle replacement when she gets it in India. Now, so what is the algorithm we should, now this should have been running over it, but anyway. So do a clinical history, examination and plain x-rays and weight bearing definitely. If it is a confirmation of a syndesmotic injuries, yes, we'll go ahead with this. If no, then get an MRI scan done. Once you get an MRI scan and confirmation of the injury, get a CT scan for a pre-op planning. In the pre-op planning, the first thing is you do is remove the hardware of the syndesmosis, and if the fibula also has an hardware, remove that as well. Perform your osteotomies, correct the length, correct the rotation, and wait for some time, or hold it with K-wires. Debride of the syndesmosis and the medial gutter. Reduce the syndesmosis with a large tongue clamp, and then depending on what type of syndesmosis you have and what you believe in, you can do a screw fixation, or you want to do a tendon reconstruction, or you want to do a fusion, depending on what the situation of the syndesmosis is. Then check for ankle or syndesmotic instability, and if that is present, then you consider for a deltoid ligament reconstruction. Thank you very much for your time, and sorry, I think there's some issue with the Zoom. Happy to take questions. Thank you.
Thank you, Pradeep sir. Great presentation. Many learning points. Few quick questions. Till what time you do the reconstruction, you do the fixation if the syndesmosis is missed? 6 months, 9 months, how will you justify it?
It doesn't matter. I think, Anish, I have not done any reconstruction with graft, but I spoken to Anish, and it doesn't matter as long as the syndesmosis is not arthritic, you could be doing it at any point of time. While if you have arthritis, then I think reconstruction is out of the question and you're looking at some fusion. Now, fusion, I have done now 4 in my cases, and I think they work really well. But it is more harder than what you think it is, because you really need to get that space between the tibia and the fibula. You need to fill with bone, and there is significant space. You need to fill with a iliac crest bone graft.
Sir, what is the post-operative, like post-fusion dorsiflexion, and do you get any change in the range of motion after the syndesmotic fusion?
No, it doesn't. It doesn't matter. As long as you get your position right, I think it doesn't matter. You may, anyway, the patient has been anyway chronically bad. They already have other contractures to restrict their dorsiflexion, so they do not miss much.
So suppose a patient with a triangular Cotton's fracture, which is fixed outside, who is reporting to you at 4 months, and you find that everything is open, syndesmosis, weight bearing, everything is open. What will be your thing? Like, how will you proceed in this case?
So again, if it has a posterior malleolus component or no?
No. Posterior malleus, medial, lateral malleus, everything is perfectly fixed. Only the syndesmosis was missed by the orthopedic surgeon. Will you put a screw? Will you leave it and do the syndesmotic fusion ahead, or you will intervene it with some other modality?
No. So I would definitely, I would get a CT scan done. I make sure everything else is all right, and especially the fibular length and the fibular rotation. If I'm happy with that, I would open it. I would take the patient for, I would not wait too long because I want to salvage it. So I will open it up, clear the syndesmosis, get the reduction, and I would fix it with 2 screws or a screw and a tight rope. I think Anish Kadakia has this funny thing about 1 screw and 1 tight rope, but I'm okay with 2 screws. But again, 2 screws, 4 cortices. That is the key thing for subacute.
Neglected, for the missed injury. Yeah, I think it's a learning point. In the neglected missed injury, when you are clearing the syndesmotic space, this is the time when you need really 2 or 3 screw fixation at least.
Correct.
Moonot sir.
Yes, sir.
How often you do require a repair of the deltoid ligament also in such a neglected injury?
So as I showed you in one of my cases, it did. So again, it is again a stepwise process. Just because we think we have fixed the syndesmosis doesn't mean that the medial side stability you may have achieved. Also, the other thing is you have to check 2 things. One is a talar shift and the other is a talar tilt. I think we keep forgetting that when we look at the X-rays, we see that the medial clear space is now all settled. We just leave it. After doing the syndesmotic fixation or any ankle fixation, you need to check in the end if your talar tilt is there or not. If there is a talar tilt present, then you need to fix the deltoid. And many times what will happen is once you've opened up on the medial side, you've cleaned up your medial gutter. That time also you will be more apparent. The medial side instability will be more apparent. So coming back to your question, how many times I've done it in the last 3-4 years? I've done 3 cases, sir.
Yeah.
So just for the beginners, young orthopedic surgeons, so what is the sequence of the fixation in the syndesmosis? Neglected also. How will you start the case?
So that's what I showed the. So again, okay. So if it is a malunited ankle, remove all your implants. Okay, medial side, lateral side. I would first do the osteotomy. Once I've done the osteotomy, then I decide if I want to do a medial side any supramalleolar osteotomy to do a correction. But if I don't require that, then I will start clearing the gutter, the syndesmosis right up to the joint line. Once I've done that, then and I'm made sure that my medial clear space is now reduced, then I will get my fibular length down so that the length is done. Then I check for rotation, I correct the rotation, and that rotation again, feel for the anterior side. And here in these cases, you would actually see the fibula sitting nicely in the incisura. Once that's done, rotation and length is got, transfix with 2 K wires. Once that's done, then put a plate, long plate, and 2 syndesmotic screws, 4 cortices, 4 mm. That's how I would do it.
Okay.
Whether this is a transverse osteotomy or oblique osteotomy, one thing, whether it is a transverse, and if you distract, do you use a graft, tricortical graft to fill that osteotomy gap?
Dr. Santpure, sir.
Yes.
I can't see, I can see only your name. I can't see next.
Can you hear me?
I can hear you, sir. I can hear you.
Okay, so about the osteotomy, is it an oblique osteotomy or is it a transverse osteotomy? And if you do an oblique osteotomy, do you use a tricortical graft?
Interesting question, sir. I've had patients who coming at 6 weeks, 2 months, 3 months, and or longer. If you can get your fracture line seen, so if you can catch these patients between say less than 3 months, let's assume, you can invariably get through the fracture line. That's what ideally you would want. But in one of the cases where I have shown in this second case of mine, I went in early and I gone through the fracture, but it is very difficult to control the rotation because if you're doing a long oblique osteotomy, the edges start to break up when you start distracting it. So just be careful. So in those cases, if you're beyond 3-4 months, a horizontal osteotomy is a very easier way to manage them. That's how I would do it. So once you have done your horizontal osteotomy, you get your length, then of course you need to put a tricortical graft in between.
Are there any issues of healing of that graft, tricortical graft?
It takes time. So I showed you in that picture, that lady, I had warned her when I was doing around 6 months time when I was removing a syndesmotic screw. I told her that if I find that there is non-union, I will put some more graft. But when I went in, the graft was incorporating. I didn't have to do anything.
And
but
is there any role of distraction, gradual distraction of the fibula with a orthofix monolateral kind of a distractor?
Sir, you can do it, but the problem is it is not a single plane deformity because the distal side you still have to rotate to reduce the syndesmosis.
Okay. Okay, Pradeep. Thank you.
And second thing is I'm not too good on that stuff, sir.
Moonot, sir.
Yes, sir.
Last question.
Sir.
Yes, sir, you are audible.
It's sometime in a neglected injuries. It is so osteoporotic bone, and when you expose the syndesmosis while manipulator, you lose a cartilage also. And there is a bony substance is lost. Sometimes it's because of the osteoporosis and because of sometimes however maybe gentle to the tissues. In a such a situation, if you come across, then it's very difficult to maintain the syndesmosis position smooth contact, do we aim a fusion at this juncture?
Yeah, so I think it's a very difficult situation, and I've not come across in neglected, but I know in acute cases I've come across only last month where I did an ankle and literally everything was falling off. So you have to be prepared. So that's why one thing is there, anatomical locking plates is a very good thing. You should have it. Also, even if you don't have much on fibula, as long as you can put some bone graft, tricortical bone graft in between the fibula and the tibia, and then pass long screws as we would do it in diabetic, diabetic osteoporotic, that type of fixation you would do it. I think that would help as well. And I would post-operatively counsel the patient that if this fails, you're looking at an ankle fusion. So I would do that, sir.
Okay, Santapure, you can share the screen.
Yes, sir. You shared. My screen is seen, sir.
Yes.
Okay, you continue.
Is it visible?
Yes, sir.
Sir, thank you so much. Gadegone, sir, President, and Secretary Dr. Karne, sir, thank you so much for giving me opportunity to share a couple of my cases. I won't go much into the theoretical discussion. We already heard the stalwarts of ankle injury. So I'll just share a couple of cases. Now it is already 9:24, so I won't take more than 5 minutes. So is that okay, sir? Gadegone, sir, that's okay.
Your screen is not moving, sir. Yeah, please.
This
yes,
is.
yes.
So this is my first case. Young man, 6 feet tall, healthy, muscular, heavy built man, more than 100 kg. So while playing cricket, he injured his ankle. So probably it was a pronation external rotation injury, stage 4. This was the X-ray taken immediately after the injury. Probably it was a dislocated ankle, and this was the initial X-ray, which is not a proper view. It is in a lot of rotation. So coming to pronation external rotation injury. So you'll usually see on the medial side, you will see deltoid ligament tear, and or maybe a transverse fracture of the medial malleolus. On the lateral side, you will see a spiral proximal lateral malleolar fracture, and it is highly unstable. Syndesmotic injury is very common with this pronation external rotation injury, and you must do X-ray from knee joint to the ankle joint, because you may have a Messenio type of fracture of the fibula, very high fracture of the fibula. So the aim is to restore fibular length and rotation, restore the ankle mortise, and ensure the syndesmotic stability. So this was his initial X-ray. You want to comment anything on this X-ray, or should I go to the next X-ray? Pradeep said this is a then properly taken X-ray.
Yeah.
Yes. Sampat sir, Pradeep sir, you want to say anything on this X-ray, or should I directly show what I did?
Sir, did you get a CT scan done?
CT scan, yes sir, CT scan was done.
Do you have it or you don't have it on this slide?
I have it,
So
yes.
Please, always, so any complex injury, so
yes.
As even Harsh said, and I had a case last week, exactly what Dr. Jain has mentioned it, where it looked like an isolated lateral malleolus fracture, almost minimally displaced. And we got a CT done, he had a posterior malleolus, which could not have been seen on the X-ray. Yeah. So after that, my tolerance to CT anyway was low, now it's become super low.
Yes. So this was the X-ray, and where you can see very higher up oblique fracture of the fibula, grossly widened syndesmosis, and also there is a lot of medial clear space.
Yeah.
Anything more you want to comment on this X-ray?
No, so I suspect means posterior malleolus is there or not, that I want to know.
Okay. Sampat sir?
Yeah, agreed, sir. I mean, we'll see CT scan. And as I said, now I will always advise MRI with limited cut CT so that patient is in same campus and will not spend much more.
Okay, CT and MRI.
Yeah.
Okay. So, is it every case you do MRI or any specific indication for MRI? Sir?
Such a gross unstable, particularly when fibula is high up, no, it is possible that many ligament will be gone here. So it is just for my information.
So should we give any specific instruction to the radiologist to look for in the MRI?
Yes, particularly deltoid and anterior and posterior inferior tibial ligaments. So that we have to tell them that we are looking for this.
Okay. So this was the CT scan. I haven't included all the cuts, so I have included these 2 cuts right now for this presentation. And MRI was not done.
Fine, sir. Okay. So we know that syndesmosis is opened up. You can see how the fibula is quite far away from the tibia, the incisura. As you can see here also talar shift as well.
Yes,
Yeah.
sir. So as the fracture was very higher up, so this is what I was asking. We used 2 screws to fix the syndesmosis. Even the patient was 100 kg plus, 6 feet tall, a very enthusiastic, athletic guy, and we did not want to take any chances. So, and then I have never used, even using 2 screws, I have not used the plate. Instead of that, I used 2 washers. But henceforth, that is also a good trick to use a small plate when you are using 2 screws.
Not necessary, sir. I think you have done very well. The only reason why we use plates in subacute or chronic is just because of the osteoporosis. If
Yes.
you have a very good bone quality, it's not necessary that you need to use a plate.
This is
Sir, can we have a lateral view, sir?
Let me see, sir, what I have. Let me see. This is only intro picture, and this was the final picture. So the sequence was we restored the length and rotation of the fibula. Yeah. We used a locking recon for the fibula, proximal fracture of the fibula. We ensured a proper length and rotation of the fibula, and then we restored the stability of the syndesmosis. And at the end, we opened it medially. You can see a suture anchor on the medial side, and we reconstructed the deltoid ligament on the medial side.
So why did you do that on the medial side? I'm sorry, I'm just asking a question. Why did you do it?
I wanted to do everything for him, best possible, whatever.
Yes, but why did you do it?
It was torn, and there was a wide. If you see the first X-ray, it was a wide gap.
So what was your intraoperative finding on the deltoid, sir? That's what you want to ask.
It was avulsed. It was torn from the malleolus.
No, sir. Okay. So just coming back, sorry, one step before that, and I think Girish have heard me talking on this, and a lot of people. So once you do a syndesmotic fixation, so again, this is for the people who are listening. Once you do your syndesmotic fixation, check for the talar tilt of your ankle joint and compare it to the normal side. If it is in excess, or if the tilt is more than 7 to 8 degrees, those are the indications for doing a deltoid repair. And I'm sure you would have found that. I'm not saying you did it wrong or something, or it was incorrect.
Yeah.
It's just a learning process where your brain knows that stepwise, and I think you did perfectly well. I think I would do the same thing. I would get the length and the rotation right. Some people may argue the fact that you do not need to do a fibular plating, but you wanted to be sure that you get your length and the rotation right, which is perfect. Then you fix your syndesmosis. Then I would check for talar tilt. If that is the case, then do a deltoid repair. Perfect.
And this patient did extremely well. I have his follow-up X-rays also. And then after a few months, I removed those 2 screws.
Sure.
Yes, sir. So this was the case.
Santpure sir.
Yes, sir.
Actually, the Devendra Patil sir has told that it should be position screw, not the compression screw. But you have seen here that both the screw are there a compression screw. They are compression CC screw.
Yes, yes, sir. They are partially threaded screws.
Yes.
One is bicortical, and then other one is not biting the opposite cortex.
It is serving the purpose. That's what we are discussing. That
yes,
previous version that the screw should be a
yes,
position screw, not a compression
yeah, I got
screw.
it, sir. Yes, so that we don't compress it. We don't overdo the compression.
Actually, this is nicely done, but contrary to the view
got it,
expressed by the Devendra Patil sir, that if you do next time, probably you need not do like this, but you use a position screw. Am I correct?
Probably a
Patil,
full thread screw should do.
Yeah, and one more thing I want to add, sir. Since he has done it so nicely, he has done proximal plating, and that's why only these two screws without plates can hold it. What was my point was, if he would not have fixed that with proximal plate, and you are asking only those two screws to do the job for you, then probably it is worth to put it through plate, isn't it? I mean, that is what biomechanics is. Why these two screws are nicely working? Because already the proximal plate is holding on fibula very nicely.
Without a proximal plate, how do we ensure the length?
Very difficult. Very difficult. I mean,
length and rotation.
So that is where then open deduction and direct visualization of your syndesmosis will be required.
Yeah.
Okay.
And here I presume you did it percutaneously, correct?
Well, this is percutaneous. Yes, sir. Now I move to my another case. Probably this was supination external rotation injury, where you get posterior superior to anterior inferior fibular fracture and a medial malleolus fracture or injury to the deltoid ligament. So this was his very innocent looking X-ray. So you want to make any comments on this X-ray, sir? Pradeep sir, Sampat sir?
Agreed, sir. I mean, it is innocent looking, and only thing is it is suprasyndesmotic. So be careful. Don't declare it as a stable fracture unless you do either stress view or see clinically. So stress view is the probably way to go.
There's a lateral fragment of the tibia is there, I think.
Yes, this?
Yes. Yes.
Probably this.
Correct.
So again, that indicates it's an unstable injury.
Yeah.
So this was his 3D CT scan. So this definitely shows this fragment, this posterolateral chip fracture of the tibia, where we expect laxity of the posterior inferior tibiofibular ligament and associated with a oblique fracture of the fibula. So anything else to be commented on this CT scan, sir? Sampat sir?
Yeah, that's good. I mean, we have to see again, rule out just posterior malleolus so that there is no posterior inferior tibiofibular, and you have already documented the anterior inferior tibiofibular. So that's good. Fibula and there is no posterior malleolus. There is a chaput fragment. I mean, that is anterior inferior. That's good.
Yes, sir. So how do we go about this, sir?
Yeah. Now again, I mean, that's an unstable injury. Start intraoperatively with stress view again. Document that it is unstable. Start with fibula plate. I will apply it on posterolateral border. Again, stress it. So again, always follow the steps. Again, stress it. Sometimes it is really stable, or if it is not stable, go there. Why posterolateral? Because then you can take anterolateral incision and fix up that anterior inferior avulsion, this thing. So you should know that if you take lateral approach, again taking one more anterolateral approach at the chaput fragment will be an issue. So posterolateral incision, fix the fibula first with posterolateral border, and then go anterolateral, fix the chaput fragment, but see that you fix up that avulsion.
Okay, so you will always have to fix the chaput fracture, or is there an indication depending
not
upon the size
always.
of
I
the
mean,
fragment?
It is only for the sake of syndesmosis if it is unstable, because now literature is very aggressive about even anterior inferior tibiofibular avulsion, because avulsions like ACL avulsions, they're better fixed, because then it will give you good union as such. But again, if you can achieve it indirectly and for the sake of soft tissue, you don't want to take more and more incision, you can pass syndesmotic screw as well, but document the instability first.
And this fibular fracture was in sagittal plane. So is it wise to put a lateral plate than a posterolateral plate? If
I
you
mean,
see
posterolateral border, I said posterolateral border. So it covers both this thing. I'm just saying it is not posterior plate. I'm just saying that it is a posterolateral border, because fibula is anyway oblique. So a posterolateral border, it goes on the same surface. So
okay.
it buttresses nicely from posterolateral to anteromedial.
Yes. This case was done a few years back. This is not a recent case. And this was his axial cuts, that the chaput fragment is seen nicely, even in these cuts. Anything you want to add on this, sir?
That's good, sir. I mean,
yes. Yes. So this was his intra-op picture. This on the left side, this is, I underestimated the instability and fixed the fibula. But then intra-op, I was not very happy with this widening of the syndesmosis, widening of the medial space. And then I replaced one of these screws with a syndesmotic screws, and everything, we could bring back everything. So this is intra-op checking of the stability, and we changed the plan and added one screw, syndesmotic screw from the plate.
Good case, sir. Please post the follow-up X-ray.
Yes, so this was post-op X-ray, and this is the final fixation. We did not do anything on the medial side.
Okay, sir.
Yes, sir. So these are the two cases. Thank you so much.
Yeah, great cases, sir.
Girish sir, Gadegone sir,
Santpure sir,
Manoj
this case needed some presentation. It is because majority of the orthopedic surgeons in practice, yes, small places, they think that it's a very undisplaced fracture. It is a perception of radiologist as well as of a majority of the orthopedic surgeon.
Yes,
this
sir.
Case explored the possibility that don't take it as a simple injury, but it's a complicated injury which needs to be addressed aggressively with the CT scan, possibly MRI also, and requires a surgical treatment to get a perfect result. So not any undisplaced fracture, whether it is single malleolar or bimalleolar, needs to be looked as a injury, is unstable injury unless proved otherwise.
Yes, sir.
So with your permission, can I start my presentation, sir?
Yes, yes.
Last one, we are running over time, sir. Sir, please unshare your screen. Santpure, sir.
Okay, I'll do stop share.
Yes.
Done?
Yeah.
So Girish will be speaking on this newer concept of relationship between this posterior malleolus malunion.
Yes, sir. Am I audible, visible, sir?
Yeah, please.
Yeah. So I will have a quick look on the importance of the posterior malleolus fixation and what happens if it is not fixed properly, and what is relation to the syndesmosis. Majority of the concepts are nicely being covered by the previous speakers. So I will try to sum up all the things and will put some new things at the end of the talk. So this is a 35-year-old twisting foot injury. So is it moving?
Yes, Girish, yeah.
And this is a CT scan showing the extremities of the injuries, which we can see that there is medial malleus fracture, lateral malleus, posterior malleus. There is the syndesmotic injury also. So I started the surgery with the posterolateral approach. I will not go in the details. So we are going midway between the posterior, between the posterior border of the fibula and the anterior border of the Achilles. This is how we do the surgery. We mobilize the peroneal tendon, identify the Weber B fracture, plate it on the posterolateral aspect. Not necessarily anatomical. Majority of the time, even I use the recon plate. After moving the flexor hallucis longus, you see the posterior malleus very easily, and you need to plate it because it was displaced fracture. So this is how the plating was done. Nothing new, just the things to add after doing the posterior malleus and the lateral malleus fixation. This is the video is not working. Yeah. So this is the probe test, which we do to test the syndesmotic instability. So this is a small anteroinferior and anterolateral incision directly over the syndesmosis, where you can identify the instability of the tibiofibular space. Although it is very clear that there is a big AITFL fragment, as Dr. Santpure sir has already mentioned, but there is a clear separation of the fibula. It's not working, but there's a clear separation of the fibula. You can separate it transversely, sometimes sagittally also. This is how we do it. We shift the probe posteriorly so that you can see the posterior migration of the fibula. Or it was unstable, so clamp was applied, syndesmotic reduction was done, and after that the probe was again inserted to see the stability. This is how the case is completed. Small medial malleus avulsion fracture was fixed with 1 cc screw, and this is how the syndesmotic fixation was done. So the message here is consider ankle as a circle and fix all the components of the injury. Fix all the components. As I said, posterolateral approach is a friend of the surgeon. You can do 2 or 3 things through one approach. Syndesmotic malreduction again is common, and it is bad complication. Stress testing is must. Mini open or the open syndesmotic reduction significantly reduces a malreduction rate. But my thing is, my job actually starts from this slide. Do you want to fix this small posterior malleus fracture? Because after fixing the lateral malleus, most of the time it comes on the place. And do you really want to fix it? So understanding the concept of the posterior malleus fragment, if it is malreduced, it can malreduce the syndesmosis. We have already understood that there are 3 sets of ligament in the syndesmosis: AITFL, interosseous, and the PITFL. This is a syndesmotic gapping you can see on the posterior aspect of the syndesmotic. Majority of the time, this fragment, it reduces with ligamentotexis with fibula, but sometimes it is not possible. There could be some periosteal trapping. There could be the organizing hematoma. We operate the ankle 4 days, 5 days, 7 days after reducing the swelling. So there could be some organizing hematoma. There could be some new callus formation if it is neglected or if it is not properly diagnosed. So it may not easily move because it's a cancellous piece. It cannot. It is not always mobile with the anatomical fixation of the fibula. So if you fix the fibula and if you don't fix the posterior malleus, but to fix the instability, if you put a syndesmotic screw, there could be the persistent instability, persistent widening of the posterior aspect of the syndesmosis, and it may heal in the same position. So after removing the screw, you can see that there is a persistent widening or the instability at the syndesmosis. This concept can be easily understandable with the simple case. So this case was fixed by some other orthopedic surgeon. He thought that the posterior malleus is very small, so let's go with the transsyndesmotic fixation with 2 screws only. This was the syndesmosis, which was nicely reduced on table, but the posterior malus was looking displaced, but it was not fixed, it was conserved. And 2 months down the line, when patient started walking and the screw were broken, let's see the syndesmotic instability, which was recurrent. And look at the talus shift here, which Pradeep sir was talking. And it is clearly showing that this is a persistent syndesmotic instability. So if the previous surgeon, if he has fixed the posterior malus, this complication may be avoidable. So, we have to understand the concept of relationship of the posterior malus and the syndesmosis. So this is a trimallar cordons fracture. Posterior malus was reduced with the fixation of the lateral malus. Ligamentotex is done. So this is how, after application of the clamp, everything was on the place, and this is how we put a screw. While putting a screw, if you just over tighten it and if you don't fix the posterior malus, this complication can happen. And why it happens? Because the syndesmotic is not just a transverse instability. This injury may give you the sagittal instability as well. And the fibula blindly follow the posterior malus. And if it is not fixed while compression, this complication may happen. There could be the rotation of the fibula. And if it is not fixed, your syndesmotic, the space may go into malunion. The another thing, if the clamp application is not proper, suppose if it is not applied on the transmallar axis, again, this is a problem with many general orthopedic surgeons, and it is difficult to decide intraoperative that what is my transmallar axis and where to apply a clamp. So if the clamp is not applied, and suppose if it is applied like this, look at the persistent posterior subluxation of the fibula. Why? Because of sagittal instability. The posterior malus was not fixed. Look at the few cases here. Fibula, posterior malus, although very small, majority of the people, they may think that we can conserve it, but see the fixation done by the surgeon, good fixation of the fibula, length achievement, syndesmotic clamp application. This is some oblique view, so uncommentable, but this is how the syndesmotic fixation was done without fixing the posterior malus. Now you can see on the post-operative X-ray what is the difference. Look at the fibula. It is subluxated more posteriorly as compared to the previous X-ray. Why? Because while putting a syndesmotic screw, the fibula was shifted posteriorly. So the undisplaced posterior malus fracture, it is looking more displaced because of the posterior shifting of the fibula and the wrong syndesmotic screw insertion. And look at the CT scan here. The syndesmotic screw has brought a fibula posteriorly, and the posterior malus is even much more displaced than the previous X-ray preoperative. So a poor outcome. Again, same case, fibula fracture, medial malus, lateral malus, posterior malus is not fixed. This is done by another orthopedic surgeon. This is what he shared with me, and he said everything was okay on table, but on X-ray he found something abnormal looking on the fibula and the posterior malus. So he shared an idea with me and said what happened wrong. While evaluating the things, I found that this is again an incongruent angle. Why? Because look at the congruence. The posterior talus is uncovered. The posterior malus is shifted more anteriorly. Why? Because of the syndesmotic sagittal instability of the fibula. And why it happens? Because the fibula was not fixed. So suppose if somebody has fixed the fibula, even it is a posterior malus, even though it is a small fracture, this complication is easily avoidable because you remake the notch for the fibula. So syndesmosis is basically an anterior and the posterior notch. So posterior notch is broken. So if the screw fixation was not proper, it may shift the fibula posteriorly. Other case, similar kind of fixation, medial malus, syndesmotic instability, Two screw fixation, very good on table. See the good reconstruction of the ankle. Good fixation, but probably this is a complication which we were discussing. A wrong clamp application, posterior migration of the fibula. Look at a post-operative exit, proximal migration of the posterior malleus. This is again an incongruent ankle. And looking at the CT scan, if it is not properly fixed, this can happen. Incongruent ankle again. So basically, if you anatomically reduce the posterior malleus, you re-establishes the normal osseous anatomy of the tibial incisura, and you restore the posterior inferior tibiofibular ligament. So more than just a bone, it stabilizes the ligament. This is what the beauty of fixation, the posterior malleus. And direct fixation of the fibula of the posterior malleus is always better than indirect fixation by the transsyndesmotic screw. This is a case which was nicely done. All components of the injury were fixed. Look at here, there is no need of putting a syndesmotic screw. Why? Because all injuries were nicely fixed. So it looks stable. Another case, same, all components of the injury were fixed. Good clamp application, good reduction of the all the three components, good outcome, 6 weeks follow-up, 6 months follow-up, good range of motion. So always fix the posterior malleus irrespective to its size, because it gives the better syndesmotic stability. So finally, in the last, this is the take-home message that you have to think, plan meticulously, think more of missed injuries, which can be avoidable with good preoperative examination. Thank you.
Girish, it's a wonderful talk.
Thank you, sir.
And any questions from all the panelists? You can stop sharing. Yeah.
Girish.
Yes, sir.
Girish, in afterthought, suppose if you want to do a revised surgery, in how many days it should be carried out? Suppose if you see a post-operative X-ray and inadvertently you have missed the posterior malleolus because it was thinking very small. But in a post-operative X-ray, you think that there is some displacement of the posterior malleolus, but the ankle is stable. In a such situation, whether you want to go it again and do the surgery in a week or so.
As far as possible, sir, we have to revise it as early, because we know the fate of this ankle. If it is incongruent on table, it will be incongruent and bad on follow-up. So as early as possible, it should be revised. Before revision, CT scan is must. You need to understand what is nicely fixed and what is unfixed. And before revising it, you need to, before redo it, you need to take out everything, like all the components from the posterolateral side. You need to see the instability, fix the posterior malleus. If it is already united or uniting, you have to re-break it, put it to the right place, buttress with the plate, and then do the syndesmotic screw fixation. But if everything is united and if it is neglected for more than a sufficient period of time, say 6 months, 8 months, we can go for the osteotomy reconstruction, as Pradeep sir has mentioned, supramallar osteotomy.
Devendra Patil sir, there is a question for you from Dr. Venugopal Solapur.
Yes.
What is your absolute indication of fixing the deltoid ligament, and how often it is required in acute injuries?
Sir, actually, I'm little conservative on deltoid side, and unless it is imposing the medial gutter, it is interfering the reduction on medial side, I will be conservative. I do not do routinely medial fixation. But in spite of, as Dr. Pradeep said, in spite of fixing it with syndesmosis, still there is a tilting, then I would touch the medial side. But generally, I am little conservative on medial side. But now more and more literature is saying that you should be fixing it. But to be honest, I have not repented why I have not done it if it is quite stable.
Okay. In cases of avulsion injuries to this deltoid, either tibial or this talus side.
Yeah, then it is really worth, because then getting good outcome is very easy. So if it is avulsion and you are fixing bone, then it is good. But if it is only ligament injury, probably I will be more conservative.
Patil sir, there are actually the medial ligament complex is superficial and deep and very complex structure, anterior, middle and posterior. How often it is possible to restore the anatomy even after repairing it? Is it possible? Because it's a very complex structure and in literature in written also that we cannot just replicate the strength of the deltoid ligament even after a repair. What is your take?
Yes, a very good question. Rather, it is now that is a main point why they indicate that primary repair should be done, because it is like, sir, when you open on medial side, everything is open. And first, what you should do is capsule along with the deep part, just suture it to the deltoid. And then superficial part, you put it on the medial malleolus. Because what they say, people who recommend repair, they say that reconstruction is difficult. Because if at all you find that deltoid is insufficient and you cannot now repair it, then reconstruction is not very easy. So, and believe me, sir, it is not that difficult, because once you open on medial side, everything is there in front of you. What you should understand is, usually it is not the superficial part. It has gone with the deep part. So just put one suture anchor on deltoid on the talus and take the deeper part to the talus, and then superficial part is little easy to put on the medial malleolus. So have that suture anchor with you to put it on talus, and it is not that difficult. You don't need to identify, sir, because it is like capsule only. It is like complete capsule, like medial collateral of knee. It is the deep part is with the capsule. So as good as we are putting that capsule again to the talus and superficial part to the medial malleolus.
So it's a wonderful discussion. Anything you want to ask, Karne sir?
The whole saying
We
that
have a closing remark from Dr. Manoj Pahukar sir.
I think Girish, you propose a vote of thanks, I think.
Like Karne sir was about to say something. Let us hear Dr. Karne sir.
the whole teaching was that if only the superficial superficial deltoid ligament is injured, and it is not that important. The deep, but the deep deltoid ligament, that is the tibiotalar component, is gone. Then it repair is mandatory. How true it holds now?
I mean, it is same, because a deep deltoid is giving more stability. So unless it is gone, it will not be that unstable. Superficial part is on the medial malleolus and little easy to repair, but it is a deep component which is giving more stability. So obviously, when it is unstable, probably we need to look at the deep component for sure.
Yeah, Pradeep sir.
Yeah, I probably raised my hand before as well, but probably didn't see that. So two things I want to mention it. So Gadegone sir, in your question, when you said between superficial and deep, I presume you're talking of chronic cases or acute cases?
No, in acute cases also, if you have a complete rupture, so it is possible to replicate the strength of the deltoid ligament after repairing also.
Yeah. So acute cases is not an issue, sir. Acute cases, if you put one anchor in the medial malleolus and take the whole bite which has come off the medial malleolus, you are able to get it, and I don't think so that is an issue. And if you look at the literature, in acute repairs is not a problem at all. What problems we are talking about is chronic deltoid insufficiency, where you have to assess how much lengthening or fibrosis in the deltoid there is, and then you have various means and ways of reconstructing your deltoid, either by tendon graft, or you repair it and you tighten it with something called as an internal brace. And I think we have just got a technique and case report published on internal brace and deltoid reconstruction in chronic insufficiency. So that is where the major issue is. In acute cases, I think as Dr. Sampat has already mentioned, is usually it is everything is open up. You need to get a nice either two double row anchors, and you take it the whole thing which has come off from the medial malleolus, you're going to get a good repair. That's not an issue. Again, that probably answers Dr. Karne sir's question as well. If you open up everything, your deltoid is really in front of you. No, so before that, I'd like to answer one more thing. If you look at literature, so I've had a couple of PPTs on deltoid, medial side as well. There is not a single sign and symptoms present to say if the deltoid is gone or not. Example, if you just go by an isolated lateral side malleolar fractures and medial side there is no tenderness, would you conserve this patient or not? So just by palpation on the medial side, you are not able to tell 100% sensitive or specific if the deltoid is gone or not. If you look at MRI scans, so there have been studies looking at MRI scans, again, it's only 50 to 60% specific of deltoid injury with MRI scan. The only gold standard which you can do is doing an ankle arthroscopy. Do an ankle arthroscopy and then see if the medial joint space is open or not, and if that patient requires a deltoid reconstruction or not. So that's what you need to do. So again, multiple level steps to assess if the deltoid is insufficient or not, and if requires surgery or not, or repair or not. Does that answer your question, sir? Dr. Karne, sir?
So, Girish?
Yes, sir. Yes, sir.
We will conclude now.
Yes, sir. Yeah, thank you, all presenters, Pradeep sir, Sampat sir, Santpure sir, for sparing the time. Thank you, Harsh, for the great discussion on the radiological aspect, which was a very important part of today's webinar. And literally, there were a lot of learning points on how not to miss on the neglected injuries, great learning points from the Santpure sir cases. Importance of the deltoid. I think these are all the upcoming points in foot and ankle where we need more evaluation, more studies, and then final conclusion can be taken off. Thanks everyone, and it was really a fantastic presentation. We will have the similar activities under the guidance of Gadegone sir and Karne sir. Thank you everyone.
Thank you, Girish, and hope to see you again. Thank you.
Okay, good night.
Yeah, bye.
Good night.
Thank you. Good night.
Thank you, Manoj. Thank you for
Thank you,
good
thank
conduction.
you everyone. Yeah.
Hello.
Thank you.
Again.
Bye-bye.
Recording stop.